Very good to have you here with us. So I'm Dr. Alba. I'm an NHSGP working at Charing Cross Hospital, just down Fulham Palace Road, and a menopause specialist. I'm also a board member of the Royal College of General Practitioners, together with Linda, representing the North and Northwest London faculty. So I would like to thank you all on behalf of the college on this lovely sunny day and being here for this education event to improve the quality of care that we provide for our patients. The session will be divided in two. The first half is going to be an educational session on HIV and on menopause, and the second half is going to be 1 hour networking, opportunity to get to know each other and connect. I would like to start the education part in a positive pathway, because over the last 20 years, the antiretroviral therapy has changed HIV to a chronic disease with same life expectancy for the patient is stable on the medication. I don't going to go much further on that because we're going to hear the expert giving us some insight. We're going to hear Dr. Joseph Heskin that kindly accepts being here with us. He's a consultant on genitourinary and HIV medicine at 10 Hammersmith Broadway. Everyone knows 10 Hammersmith Broadway, yeah? It's our sexual health clinic that we refer all our sexual health patients there. He completed his training at Chelsea Smith Hospital, undertaking fellowship on viral diagnosis and public health. His interests includes mpox, syphilis, sexual health and HIV care in detained and deprived populations. Joy provided enriched sexual health and HIV service at HMP Wandsworth Scrub. He is a clinical tutor at the Imperial College Medical School and is a foreign physician at Haven SARC, which is the Sexual Assault Referral Center. Thank you for being with us.
Pleasure. Thank you very much.
Yeah, thank you. So let's.
Thanks very much, Albert, and thank you all very much for coming as well on a very, very nice day. I'm going to talk to you a bit about HIV. Apologies, some of you might know tons of this already. It's really difficult sometimes to gauge talks to really broad audiences as to who actually looks after lots of people with HIV and who maybe has one or two people within their very large GP practices. It is going to be a bit about an update. I've got there's some disclosures, there's some people I'm thanking because I've stolen their data and their slides. And this is just a bit about GUM because I think more and more people don't see very much about genitourinary medicine, and there's a lot of crossover with community sexual reproductive health as well. But basically this is what we do as a specialty. And the focus is going to be kind of on the red side of the arrow, so more on the HIV medicine side, and give you an update of where we are at the moment. And this is generally trying to cover the areas hopefully most of you kind of work in. This is us down at 10 Hammersmith Broadway, just across, my directions are terrible, across the roundabout over there. But these are the other sort of Northwest London-based sexual health units that cover your area. So these might be the places that your patients are going to or coming from, or you might be hearing about HIV care coming from these areas as well. This is my sort of general plan. Please interrupt me as we go along. I'm very happy to take any questions at all of all sort of varieties of topics around HIV or beyond. You may start to see more and more people living with HIV amongst your cohorts. About a third of our patients still haven't disclosed their status to their GPs for a variety of reasons. But as we move into more electronic-based records and the London Care Records kicked in, hiding that status is getting harder and harder for some people. So you may see HIV diagnoses flickering up on patients' records that you didn't realise that have been long-standing patients of ours. And their care may be moving more and more into the community as well. So if you look beyond the UK, we really silo the care off into clinics, whereas if you look at the Australian and Canadian ways of looking after people with HIV, actually it's the GPs who do the vast majority, including prescribing for most people who have long-term, well-controlled HIV. This is the official action plan of the government, that by 2030, it's also a UN-driven action plan, we will achieve 0 new HIV infections and no AIDS and HIV-related deaths. I think we're absolutely not going to achieve that at the moment. We were briefly on track to do that, but a lot of funding-related issues, particularly around new options and medication that we're going to talk about from a preventative perspective, will probably scupper that, unfortunately. A bit of a language update. I think it's really always important to update our language because it just develops with time, and we've moved away from lots of eponymous syndromes in medicine, and the same way in HIV we try and keep up to date as much as possible. We do a huge amount of community engagement and work. We've just had the British HIV conference on last week, and if anyone has ever been to that, you'll see that most of our panels, as well as clinical staff up there, usually have community representatives and HIV experts who are living with HIV up on stage, which we don't tend to see in a lot of other medical conferences as well. So we say people living with HIV, we tend to say advanced HIV. We find AIDS tends to still lead to connotations of gravestones on 1980s ads, and people think of death straight away. So we were finding things like it was difficult to get our patients escalated into intensive care settings because a lot of clinicians thought with AIDS there was no hope. So there wasn't really much point in adding to that treatment, whereas advanced HIV describes a little bit more about what's happening. You may see in letters you get from us things, lots and lots of abbreviations. A lot of them mean the same thing. So antiretroviral treatment, antiretrovirals, and what used to be called highly active antiretroviral therapy. Or just a bunch of different ones, and we all mix between them interchangeably depending on what you've learned. And hopefully you'll hear a lot about undetectable viral load, so people who've got really well-controlled HIV thanks to their adherence, which means the same thing as virally suppressed, and we're going to talk a bit about that later on. This is where we stand. These are UK-wide data, so we're going to look a bit more at English data in a moment, but these are the 3 90-90-90 goals from the United Nations, that we want 90% of all people living with HIV to know that their HIV status, and of that group we want 90% of those receiving antiretroviral therapy and within care, whatever within care means for them. For some people that's coming bang on time every 6 months like they're supposed to. For some people that means they sort of wander in and out of clinic as they kind of are able to. And of those people who are accessing medication within our clinics, that 90% of those are actually virally suppressed. And we achieved that quite a few years ago in the UK at the moment. So when you work down through the 90s, we've got 87% of people across the entire UK who are living with HIV have a virally suppressed viral load, which is really, really good. So about just under 110,000 people in the UK living with HIV, 50,000 of those are in London. So London is obviously one of the hotspots for care, which is why there's a lot of HIV centres here as well. About 100,000 are in care, 7,000 or so are not aware of their diagnosis yet. That is calculated by much smarter people than me within UK HSA who do back statistics. You can see where it's an ageing population, so over half of those are above 50, so that's a complete paradigm shift for how we're managing our care. We were used to looking after very young people who lived for a very short space of time. We're now looking after people in their 50s, 60s, 70s into their 90s, and they're living the same lifespan as everybody else with some additional complications for a variety of reasons. And we see about 6,000 new diagnoses a year, which is a significant drop from what we were, but still too many, as you can imagine. This is the split, so you'll see lots and lots of talk about men, but actually women living with HIV is a huge population within the UK. They're usually underserved, both within our clinics and within healthcare in general. We see sometimes higher complication rates. We see a lot of additional complexities. Alba's going to talk about menopause being one of them. Menopause that happens earlier in women living with HIV, and again, these things often go underdiagnosed for long periods of time. And as you can see, that nice graph showing the aging population as we move through. If we focus just on the new diagnoses, and so this is from 2023, so that's the most up-to-date data that we have, you can see on the graph there's a nice drop from the people who are first diagnosed in England, a bit of a plateau around COVID, and it starts to uptick again. And some of that uptick is to do with better availability of testing. So hopefully you know about Sexual Health London, the online testing services, opt-out testing within the A&E departments across London. We've got antenatal testing, we've got testing within the prison. I've got a list of those in a while to show you, but all of that is helping to offer access to testing to people who don't want to come into our clinic, which is perfectly reasonable. And we've got to try and find as many ways as possible to offer them that test. But you can see a nice uptick in people who are previously diagnosed abroad. So when you see the original statistics, it starts to drop down when you look at what people who are acquiring HIV within the UK and England. So in England specifically, 2,800, there's been a bit of an increase. You can see there's been a slight uptick in heterosexual men and women, which surpassed percentage-wise gay and bisexual men for the first time in 2023. There was lots and lots of headlines about that. A lot of that about accessing testing, but also lack of awareness of things like PrEP amongst those groups as well. So we're not getting PrEP to the right people. And if we look then specifically at late diagnoses, so these are the real groups we're trying to focus on, because this is where the morbidity and mortality really, really kicks in. So just under 1,000 late diagnoses, by that we mean less than 350 CD4 cells. And normal is above 500. Once you hit 350, we start to see things like shingles appearing. Once you get to 200, we start to see those sort of AIDS-defining opportunistic infections start to come through. So the earlier we can pick someone up, the better their lifespan will be, the better their health will be, the better their long-term risk of things like viral-driven cancers will be. But if we start to go below 350, you can see 10 times more likely to die within 10 months, or 12 months rather, of diagnosis. And a lot of these are people who end up on our wards in Chelsea and Westminster and the other inpatient units across the city, very, very unwell, and trying to see if we can maintain their immune systems while they recover. And the solution to this is testing. So where do we test for HIV? Because that's obviously key. So we know, lots of people know about the opt-out testing in the A&E departments. It's been happening in London for many years, long before the rest of the country. It's now been rolled out because it's been extraordinarily successful, not just in diagnosing new people with HIV, but actually more so in diagnosing new hepatitis cases, and even more so again in re-engaging people with care. And so what we find is in Chelsea, across northwest London, we get emails pinging into each other's inboxes all the time saying so-and-so showed up at Chelsea Westminster Saturday morning at 5 o'clock. They'd had a drug overdose, they'd been stabbed, they'd come in with a cough or a cold or a nosebleed, but one, they're alive, two, they're clearly around. And A&E are really good at saying you need to try and get back into care as much as you possibly can. It's really fantastic from the general practitioners because they get the discharge letters coming through, and sometimes we have people coming in who said, my GP rang me and said, we know you're not in care, it's really important to link back into your HIV clinic. And actually, it's really small interventions, a bit like things like smoking cessation. It's those real small little pockets of interventions that it takes to just encourage people to go back in. We hear from some of our patients, despite we try and be really open-minded, open access, that they feel guilty that they've left us for a few years, and they feel like we're going to be annoyed at them, and they're going to be really ashamed coming back. And actually being encouraged back in by somebody else really gives them kind of the carrot to come back and see us, which is really fantastic. We obviously offer opt-in testing. There's all the online testing platforms. We're lucky to work in boroughs that all fund that, despite the impact it has on my funding. There's the substance support clinics who do really, really good access, like Turning Point, are very fantastic. We've got very close links with them. Prison and Young Offenders Institute all have opt-in testing, so everyone who enters any of the prisons, so our local one is Wormwood Scrubs where I work as well, we will offer everyone who enters the ability to do point of care, hepatitis B, C and HIV testing. I've seen 8 new diagnoses through the prison already this year. Guys who would not have been on the classical sort of HIV diagnostic spectrum, and who would probably never come in to see us in clinic at all, or they're the kind of guys who say, and I'm just going to do a chlamydia gonorrhea test and get out the door. But actually in prison they often have a bit more time than they think about their health. It's one of the few benefits of prison. The refugee and asylum reach teams do amazing stuff. The test and treat teams who come across from UCLH and go into the local hostels and run the outreach units. And then this, I think you guys are going to be the ultimate solution, because no one sees the population like GP. Even A&E don't really see everybody at all. And whether it's offering testing to new registrants, whether it's offering testing, we're going to talk about indicator conditions in a moment, you'll see how much testing you could possibly offer, is just the only way we're actually going to find people who are out there who are in that low CD4 count, who are the 7,500 who are undiagnosed. So this is what we did 2 years ago. So 1.2 million people tested for HIV, which is great, not quite enough. You can see the division there. So it's almost 50-50 between online and then level 3 sexual health services, which is where I work. Online has taken a huge amount of the burden of testing, which has been fantastic. Non-specialist services are people like community sexual reproductive health, termination services. All of us work in what's classed as an extremely high prevalence bracket. So once you hit above 1 in 1,000, you need to start testing people with indicated conditions. Once you hit above 2 in 1,000, you should be offering A&E testing. We all work in an area where over 5 in 1,000 people are living with HIV, and so we're obviously not seeing that quantity. They're out there somewhere, but that's why we've already surpassed the point at which we should be offering testing within GP practice at things like new registrants, all indicated conditions, really as many people as possible. This is what's happened from the A&E testing. This is about 2 years out of date because I didn't get something up to date one like I was hoping today, but you can see the impact from what happens when you test in A&E. So nearly 2,000 new Hep B diagnoses, just over 750 new Hep C diagnoses and 391, but as we talked about, it's the re-engagement in care, which is in the thousands for all of those categories. That's been probably one of the greatest success stories. And then this is what we have. This is what we offer when people are diagnosed, or for our cohort who are living with HIV and they need to update their medication all the time. So as with any specialty, as we get sort of new developments in medication that are out there, whether that's the route of access or the number of drugs within a tablet or the style and type of drugs, we try and offer that update constantly. So I think I saw 8 people in my afternoon clinic and switched 3 of them to a new regimen today. Everything here is a single tablet regimen, so 2 to 3 drugs within each tablet, and then the rest we can sort of mix and match. And then this is one of our newest additions, which is injectable medication, so people can have an injection every 2 months instead of having tablets. For some people, coming in to see us 6 times a year is far too much. They're sick of us after twice a year. But for other people, that's actually only 6 times a year you need to think about taking medication instead of 350 times a year. So that's a real change. A lot of people have been very, very keen to take that up. Some people are eligible, not everybody else is. That's due to viral genetics. But it's been a real heartwarming moment to see where treatment could go. And so we're waiting for trial outcomes on 4 monthly medications. And we're hoping at some point we'll get to 6 monthly, because that would be the real game changer. And I think we'll see a tidal wave of people wanting to switch then. But it has been a real game changer for some people who struggle with pills, people who find the idea that their HIV is actually quite traumatic. We have a lot of people who have a PTSD type of feeling about their HIV, depending often on how they acquired it, and that taking that tablet every day reminds them that something about them isn't something that they particularly like. And so having been able to offer them an injection is fantastic. When we look at what to choose from this sort of sweet shop, we consider lots and lots of things. So how people can take the medication, whether they're PEG or GEG fed, whether they have any swallowing issues. We have had a recent number of head and neck cancer patients we've had to switch. So we've got tablets, we have liquid versions as well for some people, what the genetic resistance background is, what the comorbidities are, because we are learning more and more that we're going to talk a lot about cardiovascular health in a moment, but that's really impacting the drugs we use and how we're changing those. The DDIs, with drugs that you guys might prescribe. And so again, we're going to look at DDIs. It's really, really common stuff that people really almost never think about because it's so generic. But that's usually the stuff that impacts the stuff that we prescribe. It's rarely the complex drugs. Side effects are obviously a big driver. The more modern antiretrovirals we use have much fewer side effects, which is fantastic compared to the very, very toxic regimens we had to offer about 10 years ago. Everything from other viral statuses to lifestyle. So, if you are traveling a lot, if you work for an airline, if you work overseas, if you work in a different time zone, if you jump time zones, if you work night shifts, if you've got kids, then actually you need to have a regimen that is forgiving of the fact that you meant to take it this morning, but actually one of your kids decided not to get out of bed, and then you've got to miss it, and you're not going to be able to take it until they go to bed at night time, or you've gone through 3 time zones and you're 12 hours out of sync. So what regimen actually is going to be forgiving of that sort of delay? And we have to accept cost, unfortunately. And so we have some restrictions on what we can do costing wise. We're pretty well funded within the HIV sector, but we have some things we need to take to things like committees where we look for approval. And this is the future. So the injectables I talked about are called cabotegravir and milpivirine. That is licensed and available. We have full access to that on the NHS, which is really, really great. As I said, every 2 months, there is a small rate of failure compared to oral therapy, which has, if you manage to take it every single day for the rest of your life, will be perfection. There's a small rate of failure, but for a lot of people, that risk is worth taking for the change it makes to their life. We're waiting for, we're running one of the trial sites for this islatravir lenacapavir combination. This is a once weekly tablet combination. Again, it's just really reducing that pill burden on people, although we're really curious to see what happens, because I think taking a tablet once a week is probably easier to forget than taking a tablet every single day. So we'll see how that pans out. If you do look after anyone with HIV, and you probably all do, even if you don't know you do, this is the Bible. This is what we use every single day as well, because who can retain the BNF in their head? This is the Liverpool HIV drug interactions page. University of Liverpool have a phenomenal pharmacology department who work really closely with their virologists and develop this. This is the international gold standard. And you literally plug in what the antiretroviral drug is, and you plug in either the class or the trade name, whatever you want, of whatever you want to prescribe, and it will give you a traffic light warning there. And if you are in the green and the yellow, you're pretty much good to go. If you're in the orange, but it's really important, you can just call us. Most of our letters from 10 Amherst Broadway have our pharmacist's email on the bottom as well, so we're really, really keen to hear from you guys if you want to prescribe something and you feel like you're not sure. Because we've usually heard it before, so we're very happy to help if we can. But these are the kind of things that actually trip us up all the time, and as I said, it's really basic medication, often that's not even prescribed, it's over-the-counter stuff as well. So if your patients are mentioning things, so we grill them on the supplements that they take, because it's cation-based supplements, any multivitamin, Pregnacare, all of these really bog standard things are brimming with magnesium, zinc, calcium, iron. Great, it's really important, it's really good. We just need to space it out from any integrase inhibitors, which is most of what we use nowadays, because at a molecular level, it will bind to the integrase inhibitor within their stomach and you won't absorb enough of it. So you end up with lower drug levels straight away. Exactly the same thing with milpivirine. We're moving away from this simply because PPIs are so commonly used, but they need an acidic environment to activate the prodrug within there, and PPIs just prevent that completely. H2 antagonists still impact it slightly, but not to the same degree. But we just have, there's so many people who will grab some esomeprazole from Boots or from Tesco or wherever it might be, or they're in a nursing home and they've got a bit of acid reflux, and it's the easiest thing to prescribe in the world because it gives people such relief, but it really interacts with some of our drugs as well. And then the fluticasone and metazone has haunted us for years, particularly from respiratory clinics, from eye drops. We've had multiple admissions with Cushing's syndrome who balloon within a matter of days because of the boosting effect of these two drugs here as well. And again, we're really moving away from it for that reason, but we've a lot of people who are still on them because they're really good drugs for some things and some people. So if you need to do that, if they need intra-articular injections, we can often do a shift, even temporarily, and we're willing to do that, but just let us know. We're very, very happy to sort of help and lead on that as well. Hopefully you've heard of U equals U. Lots of nodding, some shaking. There was a big campaign along a lot of the tubes, but not everyone gets the tube. I hate the tube. It means undetectable equals untransmittable. And it's a really, really important statement and evidence base behind it. And I think it's not okay to just give the statement, because you've got to understand the evidence, because you've got to believe in it as well. It basically means if your viral load is undetectable, which, as we've seen, 89% of people are, then it is impossible to transmit HIV during sex. It's not a low percentage, it's not 0 point something, it's zero. It's absolutely impossible. And at the beginning, a lot of people said it's low, it's a minimal risk, but actually it is zero. And the way we know that is because there was two major studies on, one called Partner, one called Partner 2, and effectively we all looked after lots of couples where one partner lived with HIV, one partner didn't. We knew that they were having sex, we knew they were having sex without condoms, and yet the partner without HIV just never got HIV, despite we were annually testing them all the time, and it just never happened. So we all had this sort of feeling that this was probably the case, that at some point when that viral load falls, the ability to transmit just decreases or evaporates. And so there was a huge study done, 1,100 couples. It actually went up to 89,000 episodes of sex without condoms, and there was 0 HIV transmission. In fact, that's just the partner one data. In the end, it was 3,800 couples with 89,000 episodes of sex. And in the second partner study, there were 11 transmissions of sex. But when we looked at the phylogenetics, so the individual fingerprint of each of those viruses, it was totally different from their partner. So they actually acquired it from a third party, which was fantastic for us because it even reinforced the message even more. Less great for those couples. That's a conversation they can have beyond the ethics of a trial. But it really, really reinforced that. And we try to impress this on our cohort a lot. And some people still don't really believe it because they spent years having it drilled into them how rigidly careful they must be during sex to make sure they use barrier protection because of the risk of transmission. And for lots of people, HIV wasn't something they acquired knowingly or wantingly, and so they never want to do the same thing to somebody else. But this does stand true, and it's been fantastic for lots of couples to be able to have sex in a way that they want to. It's also been fantastic for lots of couples who want to have children and know that they can do that incredibly safely.
What's the transmission rate to the fetus of the baby?
If you become pregnant on antiretrovirals, when you're suppressed and you stay suppressed through the pregnancy, it's less than 0.01%. So we have had we look after a very large cohort at Chelsea, and we haven't had a transmission in 10 years.
And do they end up having C-sections?
No, we don't recommend C-sections anymore unless you have a detectable viral load within the 3rd trimester, and we can't suppress you for 36 weeks. So vast majority have completely normal pregnancy. You don't get scanned more often. We monitor your viral load and CD4 count once per trimester. We actually end up doing a bit more because we see them quite often. You have whatever mode of delivery that you want. We just still don't recommend breastfeeding because U equals U doesn't apply to breast milk. And we know that breast milk carries multiple different immune cells that also carry HIV as well, so we still recommend formula feeding. For mums who do want to breastfeed or mixed feed, which is few in number but some do, we just monitor them more closely, and we test both mum and baby a lot more frequently during that first sort of period of time as well. But the vast majority have completely seamless pregnancies. This is basically what a year, I'm really sorry, I don't know what I'm doing time-wise. Please wave at me dramatically if I'm running over. This is basically what it looks like. We see people twice a year for the vast majority of people, and we will do a full discussion, everything from vaccines to medication to mental health. And we'll do an annual screen where we look at metabolic profiles, we'll look at bone profiles. We do things like menopause checks. We offer and encourage lots of screening. So we will encourage people to go and get cervical screening. We'll encourage them to get their mammograms. We'll encourage them to have anorectal screening as well. We do a viral load every 6 months. We don't do CD4s unless it's clinically indicated. So we don't do those annually. If you had one, we stopped doing them in 2017, so if your CD4 was good then, we don't do it now unless you have any change, like you might go in chemotherapy or something like that, or a biologic, we might look a bit more closely. And we give you 6 months of medication in a big packet to take away with you. And then vaccination-wise, it's a shared agreement, so there's some stuff we will do and provide, and there's some stuff we really need you guys to do as well, and I'll flag that up in a moment as well. We do the annual screening, as I said, commissioning. We're about to be commissioned by ICBs, not NHS England, for the first time ever. So we're waiting to see how much of the pot we're allowed to have. And then prevention is obviously a huge element to our role as well. So how to reduce those numbers as we go forward. And there's both pharmacological and non-pharm options as well. So hopefully you've heard about PEP. We're using less and less PEP all the time, which is great. And that's because PrEP is so available now. Treatment as prevention is the U equals U message, so the more people we get on treatment, the less risk of transmission there will be. That's called TASP. And then PrEP, obviously. If we do the non-pharm side, it's just really addressing all the additional risk factors along the way, needle exchanges, good sexual health knowledge, condom availability, antenatal screening, as much testing as you possibly can will reduce onward transmission. And just very briefly about PrEP. People know about PrEP? Wonderful, that's more nods than we normally get, that's fantastic. It's free, it's on the NHS. Good you all know that. Majority are on a tablet PrEP. There's 2 different kinds. Most people are on TDF or Truvada. We decide who goes on the next one if they have things like osteoporosis, renal failure, things like that. We now will have injectable forms coming to the market as well, but we've got nearly 100,000 on PrEP in England alone. Of that, I think at the last count, 65 or 70,000 were provided by Chelsea Westminster through our clinics, mainly through Dean Street and Soho. This is how you take PrEP. You can either take it every single day, which makes life very, very simple, or you can do what's called event-based dosing. So there's slightly different regimens depending on whether you're having inserted receptive anal sex or you're having vaginal sex, and you do that double dose 2 hours before you have sex, 1 tablet afterwards, or else you double dose 2 hours before sex and you take 1 tablet for 7 days afterwards, and then you just stop. And that means you have total control over your pill burden for the times that you want to have sex. So you might have sex at the weekends, you might have it on holidays, you might have it, plan it a little bit more, and you can then reduce the amount of pills that you have to take by doing that. And just give people control. They're very, very, very safe drugs. You may have heard lots of stuff about renal function and bone impact as well. The bone impact is thought to be incredibly minimal. It's certainly less than that of depot contraception and the impact that has on bone density. From a renal perspective, the vast majority of people, were predominantly talking about a young, fit, healthy population here. We have a huge renal service that we run specifically for our HIV and our PrEP users as well, and we see very, very few long-term impacts. Most of the people who've got renal issues with their PrEP also have diabetes, hypertension, metabolic syndrome backgrounds as well. So very, very safe drug to prescribe and to use. And this is actually the focus. This is what you guys probably, hopefully, will be most interested in. The main things to know, really, apart from menopause, which we mentioned, which is part of this early epigenetic aging. So if we look completely at the molecular level, the telomeres shorten faster in people living with HIV for reasons we don't fully understand why, but a lot of it is to do with this chronic inflammatory process. Even in the face of well-controlled HIV, there is a cellular inflammatory process that ages people with HIV faster, so they become frail earlier, they have more comorbidities, they get menopause earlier, and they end up with a lot more sort of polypharmacy profiles as well. They've got a high metabolic and cardiovascular risk as a result of that vascular inflammatory process as well. Particularly those who have hit low CD4 counts, and this is a real reason to diagnose early. You get all those viral driven cancers, so your HPV, your EBV, your hepatitis B and C, all drive cancerous processes, and so we see higher rates of cervical anal cancers and head and neck cancers and lymphoma, particularly non-Hodgkin's lymphoma as a result. And they need more vaccinations because of this as well. So you've got a threefold higher risk of cardiovascular disease, whether you're controlled or not controlled. The standardized scoring systems we have, framing them all the different key risk scores, they underestimate the impact in people with HIV, and we have yet to develop our own standardized scoring system as of now, because there's so many confounding factors within the different cohorts as well. And if you look at the global population of HIV, it's vastly different as to whether you have HIV in Zimbabwe or Switzerland, what your environmental impacts are having on your cardiovascular health. But you've got I was told earlier today, we had a talk, it was about 2.5 times higher risk of MI and a 3 times higher risk of stroke than the general population, purely by having your HIV before we start to add in all of the other effects as well. So something we call the Reprieve trial was done. I'm just going to stand up for a moment. Big trial, 7,500 participants, predominantly or a good number of women, which is rare for research, getting better. Again, an older cohort. Apologies to anyone in their 50s, you're not old, but it's older for research because everyone just hires people, get people who are 25 years old and have no medical issues at all. And you got either pitavastatin or placebo, and you can see it's really hard to argue with the results. You have 35% reduced risk of all what are called MACE now, major cardiovascular events, stroke and heart attack. So we had a lot of doubts about what statins would do or how early we would need to use them, but actually it was really, really difficult to argue against that data that came out. It is one study, I will grant you that. There are more studies that need to be done. It was done with pitavastatin, which we don't use. And so we don't know whether, statins are normally a class effect. So we don't know, but we don't know whether it actually would translate to the same percentage impact in, say, atorvastatin, which is what we would generally prescribe. But at the moment, the national and European guidelines changed to say that anyone with HIV who's over 40 should be offered a statin, regardless of the cholesterol, regardless of the triglycerides, regardless of their hypertension or their diabetes, it needs to be discussed with them and offered to them. We are doing that, and then we are mainly writing to you guys to say, would you mind continuing this in the community, because we have restrictions about as to what we can prescribe within our services, and it's limited to pretty much antiretrovirals. And so we are asking that. We've had a lot of people write back and say, I don't know why you want me to put a 42-year-old who's perfectly fit and healthy with a normal lipid profile on a drug that carries side effects. That's a perfectly reasonable question, I think. That's why, because we've got data to support it for now. That may change in the future again, but that is what we're working with at the moment. And then vaccinations. So we have official national HIV Association vaccination guideline, if you're ever interested, have nothing else to do, which is very rare in GP land, I think. You can see it's quite old, a decade out of date, so it will be, newly ones will be published either at the end of this year or early 2026. And they're just going to update the newer vaccines that are available in all of the classes, and we're learning a bit more about what to do in people who, we used to say no live vaccines for anyone. That may change. If you've got a higher CD4 count, we'll wait and see. But basically, everyone who is living with HIV, regardless of their CD4 count, is entitled to an annual influenza and COVID-19 vaccine. For pneumococcal, this is particularly important because we can't stop this. We keep trying to get access to pneumococcal vaccines within our clinics, but we've just struggled so far, I think, on funding grounds. But 40 times more likely to have pneumococcal disease if they come into contact with strep pneumonia than the general population. And having been a ward-based consultant for a while, our patients do very poorly with this. They tend to go straight to ICU with huge pneumococcal pneumonia whiteouts, and often they just die, which is very difficult when you've got a vaccinatable disease. So as per the national schedule for the standard PPV 23 vaccine, but actually we usually write, particularly with new diagnoses, to ask that the PPV 13 dose is offered just once, whatever age they might be, and then they just hit the standardized age-related 23 national schedule vaccine. We've just updated the HSV guidelines because we're moving to Shingrix is now the predominantly available one, I'm led to believe. And again, there was concern about the older ones as well. And so Shingrix is the recommended one for anyone living with HIV. If you're less than 200 CD4 cells, then regardless of anything else that's going on, we would recommend that they have a Shingrix vaccine because, again, we see quite poor outcomes from herpes zoster, and then the rest of it is just age-related as standard if they're already at that stage as well. Maybe some of you are in the room, I don't know. But there are HIV GP champions in North West London. Hopefully they've been in contact with you. That's who they are. And this is their sort of key objective. So this is something set up by Fast Track Cities, which is a huge program to try and increase the availability of testing. So they fund a lot of things like the opt-out BBV testing. But these people exist. They're doing great work. They're linking up with my colleague Nikki Backey, who's their secondary care lead. And I'm actually, I think my next slide is all of the guidance and training that they prescribe. And this is really, I think, the ask of general practice when it comes to HIV is actually, you know, you can take on as much or as little of the HIV stuff as possible, but it's things like coding so that we know that who's living with HIV, who's where, who's attending. You can contact us if you think you're out of care as well. It's keeping that antiretroviral list up to date. It's so rarely on their NHS records because we look at the summary care records to make sure we know what they're on as well. And often it's something they were on maybe 5-6 years ago that was pulled through, or it's a bit out of date. So when they're switching, it's just keeping that up to date, because if they land into hospital like anybody else, hit by a car, they've collapsed, that's where A&E will go straight to there. If you're in North West London, you can see my clinic notes. God help them for having to read them. But if they're anywhere else, it will be there that they go to. And the more up to date that can be, the better, because we can't control what's on that. It's the statin prevention, it's annual cervical smear testing, so that stays as annual regardless of your CD4 count because of your lifetime greater risk of cervical cancer. We're currently trying to introduce an anal cancer screening program for the same reason. Pneumococcal vaccine, FRAX risk assessment, that's to do with bone density from the HIV, also from the impact of our drugs over the years. In Chelsea, we will DEXA scan everyone as soon as they hit the age of 50. And anyone who's diagnosed after that, so we can adjust our drugs to make sure that they're having the least impact on bone density as possible. And really things like testing people with indicator conditions as well, supporting access to PrEP. If you think you've got someone who's in front of you who could do with being on PrEP, for whatever reason that might be, they might want it, you might think they need it, please send them in to us. There's something called the HIV Confident Charter. You may have had this as well. There's a whole section, if you're a GP practice, they will provide material training for your GP practice, how to upskill your staff. You might have really good GPs or really good practice nurses who are really hot on HIV, but actually maybe it's somebody else within the practice who just isn't quite as comfortable as everybody else is. So that is all available through HIV Confident, and they'll provide you with some accreditation to say that you've gone through it as well. All the hospitals are doing it at the moment. So if you can make the practices as HIV friendly, open as possible, that the conversation is there, you're happy discussing it. BBB screening for all new patients, it's expensive, obviously. There's no getting away from that. But I think even if you were to look at pilots, even if you were to show the impact that these kind of things could have, I will throw it out there and say that last year when I was on the ward, the sickest, newest patients that we came in were all Southeast Asian men in their 60s and 70s. And that is not the classic HIV demographic. That is not the demographic that's coming into my clinic. That's not the demographic who's going to classically go into your injection drug use centres, into your sexual reproductive health centres, because we've got a lot of those people already. We've tested a lot of those people already. It's the 7,500 who don't meet that category. So come and talk to us. We're always around. I think opportunistic discussions around sexual health are really important. I'm going to mention how you can do that in a moment, and the differences in care as well. These are indicator conditions. 2020 is still up to date for these things, but I can only imagine the number of people you see with community-acquired pneumonia, with mono, with unexplained bit of weight loss, maybe the odd peripheral neuropathy, and the number of cervical dysplasias that must come through on your screening programs as well. All of these meet the criteria for HIV testing on the grounds that they're an indicator condition, which means that greater than 1 in 1,000 people who has that has a probability of having HIV as well. So all of those, and there's an even longer list on the British HIV Association website as well, which includes a lot more cancers. But all of those I just thought were things that would commonly be churning through your books all the time, and everyone on that list meets a reason to have an HIV test. And these are all the different times you can do that. And it seems bizarre, and this is what I do exactly the same thing with the medical students I had this week, is, look at them and tell me when you can't do that. And they effectively said most of them, which is great, because it's, it challenges you, you've got to try and talk about it. But if you've got a patient who's got diabetes and they're getting lots of vaginal thrush, then sex is going to be uncomfortable for them. So you can ask them about sex, and then you can bring up, have you had any testing recently? Do you want to do an HIV test as part of that? It's good to have an MOT. If you've got someone who's had a stroke or an MI, or they've got COPD, the point at which their exacerbation may be worse, the point at which they may be most stressed about increasing their heart rate, increasing their blood pressure, might be during sex, actually. It might not be going up the stairs, they might live in a bungalow. So actually the part that they're never telling you is what their post-stroke recovery, the greatest impact it's having on their life is in their job, isn't making a cup of tea, it's actually being able to be intimate with their partner. Inflammatory bowel disease, if you've got Crohn's disease, if you've got ulcerative colitis, and anal sex is your best and most pleasurable form of sex, whether that's because you enjoy it, that's your cultural contraception method, whatever it might be, and now you've got a friable rectal mucosa with a huge amount of blood exposure, that's a really good way to get HIV and hepatitis B and C. Did anyone ask them, do they have anal sex? Are they on PrEP? Is there a way, and then you can have that talk about all these different ways, post-hip replacement, post-gynae surgery, erectile dysfunction because of diabetes, vasculopathies. There's so many different ways you can naturally tie sex into a consultation beyond retinopathy screening, peripheral neuropathies just in the feet. It's just a little bit, one more question extra, but it could be the game changer that really opens up a lot with your patient. And these, I don't want to end on downers, and I think I feel like I spend my life defending GPs, a lot of my friends are GPs, and I think they get a lot of crap in the press. But these are things we hear from a patient, and this was some data that was presented on Friday in Brighton at the national conference from a massive survey that was done on people living with HIV as well. And these were things that they said about general practice. So people keep asking me how I got my HIV. And I don't understand why, because it doesn't matter, I already have it. Those days are gone. Whether I got it from sex or a needle, whether I got it from a blood transfusion or an assault, it doesn't matter. They said they tell my wife because she's their patient and I've got a duty of care to her as her doctor, and so she should know, which isn't legally the case at all. and may be irrelevant depending on their viral load status. Every time I go and see them, they say it's probably because of your HIV or your treatment when I know it isn't, or they tell me to bring it up with my HIV doctor instead. And so 20% of them in the survey said they had some form of stigma or stigmatizing comments from their primary healthcare team, and 20% thereabouts said they avoided going to their GP because they felt treated differently. So that may not be your practice, but it's just good to think about it, because this is coming back from sort of the people who are actually heading into our practices. We're not perfect by any account at all. I'd love to see them do the same statistics for our setting as well, because I think it's really important that we are aware that we're not on a pedestal. But people do find it difficult. I'm nearly done. You'll have no doubt seen USAID and PEPFAR have been defunded by bad decisions. Just so you know where we're going with that, you can see the impact that this is happening. So Burundi's effectively lost most of its access to antiretrovirals. Ukraine has about 14 months left of antiretrovirals before they're gone. And you can see the Vietnamese PrEP program was almost entirely funded by PEPFAR, and about 91% of global PrEP was funded by PEPFAR. So if you've got patients from these regions, coming in from these regions, or going back to these regions, we're trying to be aware as well, but be aware that they may not have access to the same care or protection that we have here. This is just so you also know, this is my soapbox moment. HIV, we're funded by the NHS, that's all wonderful. Sexual health is not, it's funded by the councils. So we got devolved about 15 years ago, and we have to go through our tendering processes, and that might be a council that wins it, it might be the NHS in the case of my clinic, it could be a private group like Virgin Healthcare picked up quite a few along the way. As a result, we have an overall reduction in our sexual health budget because roads need to be built as well. And there's been restriction on services, so just so you're aware, in northwest London, we will no longer be able to see asymptomatic patients for any form of sexual health screening at all. If people want to come in and get PrEP, we can obviously see them for that. If they're vulnerable people, so refugees, migrants, language barriers, mobility issues, whatever it might be, anyone who works in the sex industry, we would of course see them. We would never turn anyone away from our doors at all. But the borough are cutting our funding, so asymptomatic patients must go through the online testing. So if you have patients who need things like pre-fertility screening, sexual health screens, you're going to send them to gynae or to urology, but you want to do a sexual health workup first, they got to go online, because we will have to turn them away because we won't get paid for them anymore, because we're paid by the test by the patient, and the councils won't pay it anymore. But anyone who's vulnerable, we would never turn away. And one more slide. DoxyPET, you may have heard about this, you may not have heard about this. This is about to happen, so you'll need to know about this. It's taking doxycycline after sex. So within 24 hours or up to 72 hours after sex, if you take 200 milligrams of doxycycline, you will reduce your chlamydia and syphilis chances of acquiring chlamydia and syphilis by 70-75%, which is quite impressive actually as the reduction goes. And who is this available for? The data only supports its use in gay and bisexual men and trans women. There was a single study done in women in Uganda and South Africa, and the data was dreadful, but actually that's not because it doesn't work. It almost certainly will work. It's just because no one was able to take the medication for a variety of reasons. The general feeling is probably to do with the relationship scenarios a lot of those women were in. We'll have national guidance by the end of 2025. In Chelsea and Westminster, we've started our own individual trial so that anyone with a new syphilis diagnosis will be offered this to continue post-treatment. So after sex, they can take this to reduce the chances of reacquiring chlamydia or syphilis as well. Obviously, big concerns, what happens to your microbiome? What happens to antimicrobial resistance? We've already had people say you guys are supposed to be giving out less antibiotics. And the answer is we don't fully know. Obviously, we've got global cohorts of malaria prophylaxis that uses doxycycline that have things like lower respiratory tract infections and acne that use widespread use of tetracyclines, and we don't see broad spectrum resistance. However, that doesn't mean it's representative in this population. So that is to be seen. And I'm done. Thank you very much.
So, any questions? Thank you so much.
Sorry if I've gone over.
No, that's perfectly fine. It's amazing to see how the HIV changed over the last 20 to 30 years. Yeah, because I'm graduated 20 something years ago. I remember when I used to go to med school. I started my med school in 1995. we used to see very sick patients on the world. Yeah? So then this is to the advance in the technology. And I think that Brazil is doing quite well as well on that aspect. England is doing quite well, isn't it, here in the UK?
Incredibly well. I mean, if you go to our wards, particularly the older ones, you'll see they're all developed on like hospice layout plans. So they all have huge rooms, big spaces, lots of places sort of for families and stuff. And we just don't use them for that anymore. We have encroaching other specialties taking our space because what I didn't show is the mortality rate has come crashing down, which is fantastic.
Yeah.
It's still too high because some people just can't take the medication for a whole variety of reasons. But yeah, England's doing incredibly well.
Yeah.
I
Good.
think that we're not supposed to ask the question that how do you get it? Like, if from the 6,000 new diagnoses that you have, what was the highest proportion from which is it like drugs or people?
Still sex.
It's still sex.
Yeah. So very, very few vertically acquired. So very, very few from pregnancy. I think the last drug use was, I think 6%. So really small numbers. So needle exchange has been a game changer, as has linked services. And actually, I look after the cohort at 10HB who are sort of the chaotic sort of group, and they're predominantly really well suppressed with their HIV. They might be sleeping on the streets, they might have a lot of meth or heroin in their system, but they are usually very, very good. And they might have blips along the way, but they will come back to us.
I'm sort of curious. Oh, thank you for this. That was really good. I'm sort of curious to hear your thoughts about our role in looking after HIV. And obviously, you've mentioned that there's a growing aging population with more comorbidities, more complex medical and probably social needs as well. And I'm curious to know your thoughts about where we're going to fit in with all of this. Is it that eventually we're going to be looking after HIV care without the need of HIV consultant oversight, or whether it's still going to be shared care, but very off-hands care? You know what I mean?
I think it will be shared care, because I'd like a job. But I think you will see more and more people coming through. I mean, already, again, I work with our community nursing team. We have a large population within the nursing homes in North West London. And we work really closely with the GPs who go into those nursing homes as well, because the availability of nursing within those care as well, the massive polypharmacy that ends up happening to anyone of that age group. So shared care is definitely going to be the way forward. I think it's been aware of the additional risks of frailty and comorbidity, so that you're as attuned as possible when people show up to see you, of the fact that you might be looking at someone who's 50 but genetically they may be 60, and so it's trying to preempt as many of those things as possible. And that will probably lead to a time where there are more services involved in that care, whether that's community physios and OTs as well. We have a community nursing team who go out and see anyone who can't come in to see us. So, if you think there's anyone on your patch as well who's struggling to get out of their houses, or they're in nursing homes, please let us know, because rather than holding them in or trying to arrange transport, we will go and see them. We will do bloods in nursing homes, in their houses, and bring their medication to them as well. But again, on the same thing, people who are on palliative care, it's actually quite important we continue our drugs in a lot of the cases as well. And we've had some really nasty scenarios where people have stopped them early and they've died of an opportunistic infection because they live a bit longer than you think they will. And actually, but their CD4s will often plummet because they may have had chemotherapy or whatever it might be. So we're really keen to be involved in as much shared care as possible. Will you guys have to take over their care completely? We might go to the Australian model. I don't know. I don't think it's going to happen probably in the next 10 years. But I do think, because it's such a chronic condition, we will just see people living longer, greater populations for a period of time as they age, and more comorbidities. So they'll be in your retinal screening clinics, they'll be in your diabetic clinics, they'll be in your asthma follow-ups, they'll be in your COPD follow-ups. So it's drug-drug interactions, awareness of early aging, I think, as well, and then, good communication.
This may be a bit of an unfair question, but is the HIV programme as robust outside London as it is inside?
Yes. So sexual health, no, because they're really difficult. The funding outside London is really low, but HIV care is fantastic. And actually, I would say we've got huge populations. So at Chelsea Westminster, I think we look after about 22,000 people. Once you leave the city, their funding is not good, but their dedication is unbelievable. And so you still have lots of clinics where people, consultants, nursing teams are driving around to people's houses to check in on them and knock on the door to say we haven't seen you in a few weeks. So it's really, really, I would say it's very, very good. But you can get your HIV care anywhere you want in the country. So we have people who get the train from Edinburgh, drive from Cardiff, because they either were diagnosed in London or they got their care here for a while and they want to stay here. So you can travel as far as you want for your care. Yeah.
I wondered, for your pregnant HIV patients, is there a joint clinic with obstetrics and HIV? It's a joint one.
Yeah, so we run 2 antenatal clinics every month. So we have a specialist HIV midwife. We have a group of us then within the department who have an interest in that area as well. There's 2 pan-London MDTs. There's a paediatric MDT for all the kids born afterwards. So we will do 2 years follow-up. And we have a specialist obstetrician as well. And then we run a postnatal clinic. So we try and keep an eye on everyone as much as possible. Because it's always, despite the data being really good, a lot of mums are really tense the whole way through their pregnancy. And we still give neonatal PEP for 2 weeks after delivery, even if everything's been perfect the whole way through. In Switzerland, they stopped doing that and they haven't had any new transmissions because they believe more in the data than we do. But we follow everyone very closely. And if you have anyone who's living with HIV and they want to talk about like fertility and starting a family, they can see our midwife as well. She'll talk them all through that process too.
Thank you so much.
No, thank you.
It was very informative. The service that they provide, sexual health clinic provide, and the HIV clinic provide, it's amazing. We hardly need to contact you guys for any input with at least on the GP that I work, because it's everything done like in a high standard. So thank you so much, and I hope that the fund is not going to be too much effect for you. What I'm going to do with menopause, I'm going to go very quickly to the slides, and then I'm going to open for questions, just because we are running a little bit out of time, but it was brilliant. No, we need that, because I can ask for the college for any time for another presentation on menopause, that's fine, and the HIV, thank you so much for that. So menopause, and it's exactly the same reason, is because the population is getting older, and then we are living and dealing with the consequence of the age in population. I have no conflict of interest to declare. I'll go very quickly with understanding menopause, symptoms, diagnosis, management, and menopause and HIV, and then Q&As. So understand menopause. I think that this one is quite, it's quite visual, and it's very good to understand, because a baby girl is born with 1,000 ovarian follicles, a million ovarian follicles each ovary, so it's 2 million by birth. So when she reached the menarche, the first menstruation, the first period, these already went to half, is already like 500,000. Evolution, natural selection, because the body gets rid of the one that does not work properly. So when she reached the beginning of the perimenopause, that is like the age of 40, she only have 8,000. So can she get pregnant? Yes, she can still get pregnant, but the probability is much lower. So, and it's not only an issue in fertility, it's other issue as well. The issue that comes together with the decrease of the ovarian follicles is a lot of issues that comes together with the decrease in the estrogen. And after the menopause is less than 1,000. And there is not only a decrease in number, but there is a decrease in quality. So they do not produce enough or estrogen at all. I will be going very brief on these slides, because everyone knows that the only thing that matters to give the diagnosis of menopause is the last menstrual period, is 12 months. However, I kept these slides because everyone knows, and it's on the books and the NICE guidelines and all our guidelines, that the average age of the menopause in the UK is 51. However, we need to bear in mind that these studies was done in white Caucasian. Yeah, so this is the data for the white Caucasian. So we, for the GPs, for us that see the other ethnicity, for instance, African American is 49, Asian is 47, Pakistan 47, Indian is 46, and China is 48. So just bear in mind of this population, because they going to come, or the symptoms of the menopause is going to be earlier, the perimenopause is going to be earlier. Anything below the age of 45 is early menopause. Anything below the age of 40 is POI. However, the early menopause on that ethnicity, on that population, is going to be earlier. The POI, the premature ovarian insufficiency on that population is going to be earlier, and it's 10% of early menopause is 10% of the female population is going to early menopause. Some other also has to do with ethnicity. Some ethnicity is the percentage is higher, and 1% for POI, and 0.1% if it's below the age of 20, and then 0.01% is the one that is a primary amenorrhea that never got to the period. A little bit of criticism for the NICE guidelines on that slide is the recent NICE guideline was recent updates in November last year, is because there was a lot of good things, but there was some criticism. For instance, they were very good on POI. The POI, they have proper guidelines, say, please give the estrogen HRT until the normal age of the menopause, which is 51. They gave clear guidelines for us on POI. However, they consider early menopause as menopause in stage of consider. For instance, if a lady has a menopause at the age of 41, no, you just go for the guidelines in how do you give the HRT in stage of the age of the menopause. So we need to bear in mind that that lady, if she has early menopause, she is going to live. This is almost 5 years gap with the decreased level of the estrogen that's going to have a long-term consequence, which we're going to talk a bit more soon. So symptoms and diagnosis, we know, we are GP, we know the symptoms and diagnosis. The reason that I left the GP is that's the way that I do on my consultation, because it's easier to, I found it easier to manage if we need to do the alternative medications, yeah, in the field. If, for instance, that patients that it's very difficult to manage on the HRT, it's very difficult to progesterone intolerance, that we need to try alternative medication, that is much easier to manage. For instance, vasomotor, I divide. Do have vasomotor, and then I ask her, I specifically put on my consultation, vasomotor, any mental health, any genitourinary syndrome of the menopause, and then all others, because others can be managed with something else as well. Yeah, so we're going to you guys going to understand when I'm talking about the management and alternative therapy. Diagnose. If it's above the age of 45, it look like a cat, meow like a cat. Have you seen the slide of the decrease of the ovarian follicle? It's menopause. So instead of trying to measure the FSH and be misguided, because in the moment that you do the FSH and then the patient say, oh no, but it's normal, because it's very unreliable. It's unreliable even throughout the day. Can you believe? It's very difficult to get one spot that the FSH is going to give you a true value on the perimenopause. So just the best thing is just treat for 3 months and review the symptoms. Do or the FSH when you are having that patient that you have no idea what's going on. We don't know if it's rheumatoid arthritis. We don't know if you are going to, you don't know if it's mental health. You don't know if you are, how often do you have that kind of patients that we are sitting there saying, what's going on there? So then check FSH just perhaps can guide you somehow. Under the age of 45, please do. And because we need to be a bit more aggressive with them on the treatment, yeah, even if you are not suspecting, but just put FSH there. Yeah. But the most important is the baseline. The most important, because she's getting to the age of 40, and even if she's POI or even if she's early menopause, that's below the age of 40, if she has the decrease in level of estrogen, she is going to, the cardio is going to be affected, the bone is going to be affected. So it's very important to have a thyroid function, a thyroid test, because the majority of the POI, there's a lot of autoimmune relationship between thyroid and other immunological disease related with the premature ovarian insufficiency. To have a proper blood sugar, a cholesterol, to have because in the moment that you spot a raised lipid profile, it's going to be easier for her to engage on the lifestyle management, which is so important on that time. Fine. And management. So management, the management, basically the first and foremost is lifestyle modification, because the estrogen, it's the decrease of level of the estrogen. The estrogen is proactive, yeah? So the decrease of level of the estrogen decrease the metabolism. So diet is very important, because increase insulin resistance. Exercise is really important. And I don't go to go much on this one, because this is not only for the menopausal age, but this is for men, for kids, for women, for all our patients. Then we go to the HRT, which is the basic, what does she need to do is you need to replace the estrogen throughout the month, yeah, because of the decrease on the follicular numbers. The progesterone is the necessary one, that there are so many ways to give, and some patients need it, other not. And the testosterone is the neglected one, because the British Menopausal Society, they support us to give for the hypoactive sexual desire disorders, which is low libido. Yeah. However, we know that's a postcode lottery. Some clinics, some GPs does not want, because it does not. There's not enough research, and they say so many other skills, but they don't want to prescribe. Yes, and then we need to prescribe under the menopause clinic, and it does improve the libido. Yes, but improves. We know the patient improves even the mood, improves the strength, is putting muscle strain, improves so many other aspects of the menopause on her life, and with very little side effects. Tibolona, I put tibolona there because tibolona, just for us to remember that tibolona, it is because the tibolona is a synthetic hormone analog, which we used to use quite a lot in the past, and it's not being used much nowadays because of because we are using much more estrogen and micronized progesterone, which is fair point, good, because we are using the body identical. However, the tibolone has its place, yeah. Tibolone is still very good, is a synthetic, of course, that you need to balance the risk benefit, breast cancer and risk benefit. However, it's still a good medication, especially for the patients that are intolerant to progesterone, because it's have a weaker estrogen, a weaker progesterone, and a weaker testosterone. It's very good for the patients that has surgical menopause, the one that has to remove the ovaries, and then they're going to have all of them, because with the removal of the ovaries, you cut half of the testosterone production, because it's half on the ovaries and half on the adrenal glands. So it still have its place. So don't forget about tibolone. Yeah, of course that the risk, the contraindication is similar, because it's breaking estrogen, testosterone, and progesterone. So contraindication is similar. Yeah, so not for breast cancer. Contraindication is similar. So the no hormonal therapy. The no hormonal therapy, the first and foremost will be the SSRI and SNRI, especially the venlafaxine in very low dose, start with 37.5 and increase to 75 maximum. If you need to increase above 75, think about perhaps is not due to the decreased level of the estrogen, but perhaps it's going to be due to the decreased level of the serotonin. The patients that's decreased level of serotonin, they need a little bit of higher dose, 150 to 375. Yeah, we manage the menopause patients in very lower dose. Or the other one that we can use is the escitalopram, very safe. All the others, fluoxetine, we know that fluoxetine, because the reason that we're going to be used, the main reason, there are so many reasons, but the main reason that we're going to go for SSRI and SNRI is breast cancer patients. Yeah, so we need to bear in mind that she might be using tamoxifen. Yeah, so and then we need to remember that the SSRI have interaction with tamoxifen, especially fluoxetine and paroxetine. However, the citalopram in lower dose, they don't have interaction with tamoxifen, but in higher dose they do interact with tamoxifen. So to be safer, stay with venlafaxine and escitalopram and see how it goes. Fezolinetant is the new kids on the block, although it's not new, because we are using for more than 1 year and 2 months, something like that. It's not available under the NHS, unfortunately. It was supposed to be available now in April 2025. However, I don't know if you guys received the email from MHRA saying, oh, there is a lot of liver issue, we're not going to be accepted under the NHS yet. We knew that it can affect liver, exactly the same as so many other medications that affects liver. And we're going to request the liver function test before and liver function test after 6 months. So we just need to monitor, but it's not available still on the NHS, and it's been very good for vasomotor symptoms. symptoms. Remember that we divide the symptoms in vasomotor. That is only for vasomotor symptoms. Why? Because the fezolinetant is a neurokinin 3 neuron analog. So what they do is, because in the past we thought that the hot flash, night sweat was just because the hypothalamus gets a bit crazy, and in fact it is. However, now we found out that the neurokinin neuron, they don't react very well with the decreased level of the estrogen. The decreased level of the estrogen, the neurokinin 3, just gets really crazy and fire to the hypothalamus, and then the hypothalamus fire in hot flash and night sweat. The fesolinitants, they sit there on the receptor, and the neurokinin 3 neuron thinks that there is estrogen, but doesn't have estrogen. So it's very good for the vasomotor symptoms and for the ladies that with the breast cancer, because it's not a hormone treatment. So it's very good, about 50 to 60 pounds per month, so privately, but you need to bear in mind that this private patient, they need to have a consultation, so it's about 100, so it can review, so then it can be a little bit cold, yeah, so it's a shame that it's not yet, that we should fighting for that one, but let's hope that's going to be there soon. Clonidine, please don't go near that. I don't know why it's still on our guidelines. It's not on the guidelines on the American Menopause Society anymore. I think that the Australian, they removed as well. Is a blood pressure medication. So you want to stabilize, you want that lady to have a better quality of life. You don't want to mess up. Not even the cardiologists use much clonidine. Why are we going to use? So they cause hypotension, and they can cause a rebound hypertension. So no, I think that hopefully it's going to be out of the guidelines soon. Pregabalin, gabapentin, and pregabalin, for the same reason, is a controlled drug. Why are we going to put our menopause patient in a controlled drug? To give her like drowsiness, dependence, she's going to fall, she's going to break a bone, and then she's going to end up in a much worse situation. And oxybutynin is quite good. It's quite good for the breast cancer patient. Oxybutynin is used for overactive bladder. So remember that oxybutynin, the side effects is dryness, yeah, dry mouth, dry tears, dry vagina. So and then just remember that ladies with like tamoxifen, not that so much tamoxifen, aromatase inhibitors, they have a lot of vagina dry, they have a lot of vagina issue. So and then we just need to balance the risk benefits. How much, and only for vasomotor symptoms as well, how much does it going to improve the vasomotor symptoms without worsening the side effects of the dryness that's caused by the side effects of the cancer medication. So genitourinary syndrome of the menopause, the best treatment of the genitourinary syndrome of the menopause is the topical estrogen. And the systemic absorption is minimal. 2 months ago, I was in a talk, an oncologist talk on the Royal Marsden Hospital, and the oncologist, the breast oncologist, was giving a talk. I even took a picture. I say, well done. She is completely defending the use of topical vaginal, topical estrogen. The systemic absorption is minimal. At UCLA Hospital, we have patients there with the vagina